Again, welcome everyone. My name is Darshan Mehta. I'm the Education Director for the Osher Center for Integrative Medicine at Harvard Medical School and Brigham Women's Hospital. I'm also the Medical Director for the Benson Henry Institute for Mind-Body Medicine at Massachusetts General Hospital. And it's my really distinct honor and pleasure to introduce this panel. This is really going to be a panel that we entitled Listening to Our Patients and Our Communities. And we are really honored to have several distinguished panelists and discussants for this important dialogue. And it really meant to be a continuation of what Dr. Frashon mentioned just previously in his comments, really thinking about from the individual or even cellular level and what are its implications to the community level. And hopefully in this dialogue, next series of dialogues, we will talk about the community level. So with that, I would like to introduce my colleague, Dr. Ashwini Nadkarni. She's the instructor of psychiatry at Harvard Medical School, assistant medical director of Brigham Psychiatric Specialties, and associate vice chair of wellness in the Department of Psychiatry at Brigham Women's Hospital. Her research interests are innovations in inflammatory bowel disease treatments, occupational burnout, and digital health technology and healthcare disparities. She has authored numerous book chapters and peer-reviewed articles and was featured as an expert commentator in the documentary film, The Observed Life. And she's a contributor to Psychology Today and regularly quoted in Wall Street Journal, Washington Post, Shape, Glamour, and other publications. So with that, I will turn it over to Dr. Nadkarni.
Thank you, Darshan. So I'm very excited to be here today to talk about what it means to be at the front lines of clinical care and psychiatry as a South Asian treater. For this talk, I have no conflicts of interest that are financial to disclose. And my objectives today are to provide an overview of mental health concerns in the South Asian American patient population, to describe an approach to clinical evaluations in psychiatry, which integrate an understanding of South Asian culture, and to engage with all of you in what I hope will be a rich discussion by providing some case vignettes to stimulate some discussion on what it means to take an empirically supported, evidence-based, culturally informed approach to our patients. So I want to take a step back and provide some insight into why it's so important to take stock of our own identities when we care for our patients. And it's really because we bring who we are to the forefront of care. It influences every aspect of what we do and how we interact with our patients. So what I'm going to be discussing here is a little bit of what it means to be who I am, and then a little bit more about how I bring that sense of identity to care of my patients. So first, who am I? I am Ashwini Nadkarni, and I was born in Goa. And if you have never been to India or not familiar with the geography of that country, this is a state a little bit closer to the southern tip. And when I was about 3 months old, my family moved to Shikotsimi, which happens to be the origin of Celine Dion. That's what it's famous for. And I lived in Quebec for 9 years. In the 1980s, that was an interesting time to live there. It was actually fairly rural and homogeneous. And it was also a time period of the Quebecois or French-Canadian separatist movement. But in 1990, my family moved to Massachusetts. I am a second-generation immigrant, and I bring a lot of that identity with me to care. You know, my parents moved to North America as like many immigrants for a better life for themselves and for us. They wanted to do something for posterity, but they tried to raise us with a sense of their cultural origin. And for the purposes of this talk, I'm defining culture as a cross-section of the language, the values, and the behaviors of a group of people. So for my parents, you know, Indian culture for them was about collectivism. So the family unit was important. And my family identifies as Hindu. My parents felt it was very important for us to understand Hindu philosophy and Hindu mythology. And the stories that my father would tell me and my sister when we were growing up of Hindu myths really seeded in me a love for narration. And that's partly how I became so fascinated and passionate about psychiatry. What I bring about my identity to care is that sense of perspective of an immigrant. What is it like to be somewhere new, to learn about a new culture, to feel different than others, while at the same time wanting to belong? I bring that really intense sense of curiosity to every meeting with any patient. Now, in providing a brief overview of mental health issues in South Asians, one key point that I do want to highlight really relates to barriers to utilization of care of allopathic medicine. In the 10 years that I've been practicing beyond residency, I have actually treated a very limited number of South Asian patients. And I think it's really important to acknowledge that Western models of care can leave our patients feeling unable to share concerns because we have a psychiatric nomenclature that's pretty culturally uninformed, right? We know that there is need. Yesterday, from Dr. Alegria, we heard about the National Latino and Asian American Study. And this was a comprehensive assessment of more than 2,000 Asian Americans and found that Asian Americans can have as high a lifetime risk of psychiatric disorders as almost 20%. Similarly, in another study conducted in the UK of older Pakistani and Indian men and women, they found that rates of depression and anxiety were nearly 3 times higher than similarly aged whites, and that was after adjusting for socioeconomic status. So that need may be there, but why are South Asian patients not coming to allopathic treatment? There may also be culturally specific beliefs about causality, and that prevents disclosure, right? Western society accentuates autonomy, volunteerism, individualism. South Asian society may accentuate interdependence, relatedness, and collectivism. There may be culturally specific beliefs about why some conditions are resulting. As an example of this, in my family of origin, I mentioned being Goa. So in Konkani culture, we have this belief about the 4 humors, right? And that's not dissimilar from where medicine has been, where allopathic medicine does originate from. But at the same time, having this belief, one of those humors is what we call pitta. And in English, that translates to bile. So when a person has a lot of pitta, they may be more likely to be anxious, to be edgy, to be angry, to be saddened. So that may be a belief origin, which keeps us from necessarily seeking care. I had also mentioned the language of psychiatric terms differs across cultures. We have the DSM and ICD classification system. They adopt a relatively universal view of mental health disorders because they're minimizing the role of culture in that diagnostic classification. Collectivism may influence perceptions of illness. It's the idea that the family has priority over the individual. So when that happens, it could potentially disrupt family cohesion to articulate concerns about oneself. Others in this forum have brought up expectations of stoicism, but also stigma, right? An individual within the family may be expected to hold back on self-disclosure about their emotions, or there may be a sense of disgrace or shame associated with that disclosure. So key point here is there are some barriers to care that are worth addressing. So we're here to talk about the lived experience of depression because it's a leading cause of disability affecting nearly 350 million people worldwide. What do we know about depression in the South Asian patient population? Well, we know that affective mood disorders are the most common among mental health disorders in South Asians. We know this from studies coming from the UK also, that some key risk factors for depression in the South Asian patient population include overage, reduced literacy, financial difficulties, conflict on gender roles, perception of illness, social isolation, and poor physical health. Another key point that comes from my observation at the front lines is that in our Western society, we often describe depression in relationship to concepts like guilt, individualism, decision making, self control. However, the Eastern expression of depression really reflects the integration of body and mind. And so there can be a widespread occurrence of somatic symptoms in place of affective ones. For instance, patients may come to care complaining about issues with appetite, headache, backache, stomach aches, insomnia, or fatigue. And that really brings me to a key point of highlighting somatization, the interpretation of psychological symptoms as medical, which can encompass trauma, depression, and insomnia. In the DSM criteria, when we talk about a somatization disorder, it's really defined as the excessive thoughts, feelings, or behaviors related to somatic symptoms or associated health concerns as manifested by at least one of the following. Patients will have disproportionate and persistent thoughts about the seriousness of one's symptoms, persistently high levels of anxiety about health or symptoms, and excessive time and energy devoted to these symptoms. While there's limited research on somatoform disorders in Asians and South Asians, again, I think it's important to consider the cultural perspective on this, that within the construct of South Asian culture, this may not necessarily, depression may not, their somatization disorder may not be a somatization disorder, right? It may actually be an expression of emotions and reflects that integration of body and mind. I do want to point out one component here, which is a culturally bound somatic syndrome, which is defined as a combination of psychiatric and somatic symptoms that are considered to be a recognizable disease within a specific society or culture. And highlight that, in Indian culture, we have That syndrome, which commonly presents with features of depression, but also anxiety, multiple nonspecific somatic symptoms, sexual dysfunction, fatigability, and impairment of concentration, which is attributable to sleep loss. So I want to now shift into some clinical principles in a holistic evaluation that are informed by my South Asian identity that I bring to that forefront of care. First, one key core concept is that of empathy. What is empathy? I would define it as, even when we have not experienced what our patients have, that we can try to understand what they're feeling, right? We can try to share what they're feeling, but recognize that we have not experienced what they have. Empathy involves having a sense of curiosity and making no assumptions, right? It's very easy to come to the table with assumptions, to come to the table with a heteronormative, gender binary view, projecting Western cultures of ideals and attributes. But instead of doing that, we can make no assumptions and really try hard to have curiosity, to ask questions rather than come up with answers, right? To wonder rather than to tell. So that's a key core concept, empathy. Transference is this idea that patients' experiences with people and places throughout their lives will influence how they interact with us. And similarly, we will have experiences with people and places in our lives, which will influence how we interact with patients. Transference influences clinical decision-making. And when I am working with a patient who's South Asian, I try to have a lot of self-awareness about my own counter-transference to remind myself not to project ideas, values, or beliefs that are based on my own culture onto my South Asian patients. Another core concept is that of collectivism, emphasis on the need and the goals of the group as a whole over the needs and the desires of the individual. This is so important because issues related to ethics are often tied back to a sense of autonomy, right? But a cultural perspective involves, in caring for South Asian patients, involves understanding that concept of collectivism, where relationships with other members of the group and the interconnectedness between people play a central role in each person's identity. Lastly, we've talked a lot in these 2 days about stigma, that sense of disgrace or shame that may be associated with a particular condition. Even when a patient comes to care or an evaluation with me and is really seeking treatment, I try very hard to be aware of the possibility of stigma, that it's key to explain and clarify what the options are that I'm presenting to patients, right? I'm always offering them choices. I'm not necessarily insisting that they consider treatment, but rather offering them choices. So briefly, I'm highlighting today a fictional case, but one which integrates some of these values. So this is a 52-year-old Indian American woman with a history of rheumatoid arthritis, worried on edge, ruminating, concerned about her daughters, unsure how to cope with their stressors. She asks, what should I do to help them? And briefly, as we transition to our next panelist, this is a case that made me think a lot about collectivism, about countertransference, about projection, and about remaining open and curious. So thank you for your time today. I hope I highlighted some key aspects of being on the front lines, and want to welcome my colleague on stage.
Thank you, Dr. Nadkarni, for such just setting the stage for just thinking about this again from a not just an individual level, but at the community level. I believe, let me just make sure Dr. Kevin Simon is on. Is that next? We can... Okay. So while as I think there may be a little technical issue, so I will wait for Dr. Simon to come on board here. Dr. Levy, I'm going to invite you. We're going to move into a discussion here because I think Dr. Nadkarni just brought up an point. So let me just move this into a panel mode real quick so that we can all see each other. And apologies here. Okay, and just as by way of introduction, all of you met Dr. Levy yesterday, but I do want to give him really a proper introduction. Dr. Don Levy is the medical director of the Osher Clinical Center, and he's a board certified internist and assistant professor of medicine at Harvard Medical School. He has taught students, residents, fellows for many years, and has really worked on building a team-based approach, a multidisciplinary team that is embedded in academic medical centers, really developing a language both around research, clinical practice, and ultimately, how do we apply these, translate these principles into maintaining good health and ability to heal, and really those principles towards our patients. And so I'd like to, Don, I'd like to just invite you to have some comments for us and in terms of your just initial thoughts of what just Dr. Nadkarni said.
I thought that was one of the best talks I've heard this conference, Dr. Nadkarni. It really struck me that we're bringing now that we bring who we are to our care, and that culture is everything in a way when it comes to actually treating someone and understanding their lived experience of depression. And I guess I'm a slight dissenter in general of, or one who would put in brackets all of the brain chemistry or brain correlates of human experience, because nothing gets closer to what we actually do and live than what we just heard. That was so beautifully done. I thought empathy, countertransference, things, I don't know where they go in the brain, what part of my amygdala, what's working, but I have to do something about that, as you do more, and collectivism and stigma, and trying to belong. Where do these fit? They're not just simple brain correlates. So I have this, which I'd be happy to debate with anybody and discuss, that I keep in the back of my mind that brain correlates of human experience, I call them deeply superficial. They're very deep. It's amazing what we've learned. The stuff Dr. Friccione, I mean, amazing. Dr. Silverswag, what we're learning about the sub particles of the brain are amazing. But we always get back to a lived human being, and brain correlates are great, and I'm sure they'll help going down the road. But everything that's important was just said. What you just said, I think because we all come from a culture. We could substitute South Asian for white male, person, whatever I am, wherever I fit, what tribe. And I have to bring all of that to what we do. And I think we could just never forget that, because that to me is integrative medicine, is bringing the whole person, and the things we said yesterday about bringing our own brokenness, our own woundedness, and the difference between fixing the broken part, fixing the chemistry, and so therefore being cured. I'm no longer depressed. I can go to work. I can do my duties in life. But am I whole? Have I become more whole? I don't know how we'll have a study, a randomized controlled trial on wholeness versus cure, because often the measurable drives out the important. But it's everything. It's everything. If a person goes to you and we were just joking beforehand, you didn't think you did that much for your patients, and you never know. You may have changed their life in one simple recognition of their stigma, of just having empathy. It changes everything. It's what's kept me in for 40 years of loving medicine. It's those wonderful moments. It can happen every day where you just reach somebody and you feel like they're becoming a little bit more whole, and you were part of that. So to me, I was very touched by that. It's an interesting way, because we have this dialogue here of we're going from brain chemistry and all and neuroscience to culture, and that's where we are today. What a wonderful balance, because they're both important. I mean, we're going to come up with ways. Dr. Nadkarni, there's someone that needs transmagnetic stimulation, and there's someone that needs all these things, but they will come through your good discussion with that person and to helping them become whole, and them understanding she's on my side. She wants me to get through this, and this sounds like it could work. I'll do it because she said so. Anyway, so I'm gushing on about it. I was surprised to just sit down and listen to such a great talk, because it covers so much of what I think our theme is.
Thank you, Don. Dr. Nadkarni, just one question that's come in is, can you clarify a bit more about the concept of collectivism? This is, I think, a new word from just these last couple of days we have, versus having an individual approach in clinical settings.
Yeah, so I think it's best illustrated with an example. I have a lot of patients who, when they come in, we're often taught, when they come in with family members, right? We're often taught to say, okay, you wait out there. I'm going to talk to this patient first, and we're going to conduct care in this manner. And I think the way that I sometimes operate differently as a South Asian treater is I will say to the patient, you come in with me, let's talk. Then let's bring in that family member. How do you feel about that? Do you have concerns or questions about that? What do you think? And they'll say to me often, yeah, I want that person to come in. Like, let's talk to them too. And I'll bring in that family member, and I'll make that extra time. Another example is, in my patients who are South Asian, I often do have their family members calling me on their own and expressing concerns or questions. And I think it's, we're sort of reflexively taught to say, I can't talk to you at all, basically. I can't divulge any information. I can't call that person back. But actually what I will do is I will often call that person back and say, I want you to know I can't reveal what's going on in treatment, but talk to me. Tell me what is going on. What are your concerns? What are your questions? And that is based on a perspective of when I treat the patient who's South Asian, I know that I'm oftentimes also treating the family. And I want to point out, I don't want to project my perspective of South Asian culture onto that family, right? That's an important point. I can't necessarily assume that they want to conduct care that way. But I often engage patients on these issues and say, how do you feel about your family being a part of care? What would it be like if they called this clinic? How would you feel about that? And then I will sometimes navigate, the grays of medical ethics based on that cultural perspective. So the idea that, in collectivism, we are interrelated, that there's some priority given to the group or the whole system, the whole society, versus the single individual sitting in front of us, that's made by in the front.
I'm gonna pose another question to both of you, and this is something I also have thought about quite in my own career as well, is dealing with stigma. And what is it, particularly obviously there's just stigma overall as it relates to the nature of depression and how we address it with both our patients and their family units or whoever their unit might be. But also, particularly maybe there is a cultural lens of stigma that is also hard. I know as a fellow South Asian that there is a tremendous amount of stigma against getting care for, particularly for depression. It's seen as a sign of weakness potentially, or it may be seen as, there may be other ways that are, and often not a pharmacologic approach is often dissuaded initially right off the bat. And it's not to say that that may or may not be the right approach, but it's off the table from the get-go. So I'm just curious, Don, I'll start with you first. Like, just as you've seen a broad patient population over the decades, and just thinking, what have you learned? And maybe if you're willing to share even a mishap that may have happened in thinking about stigma.
I guess I think Dr. Jung got into this a little yesterday with a Chinese patient, that they'll express things that you don't understand and you need to ask more. Just listen, and say more about what's going on. And when you just said of mishap, when I was a young doctor 100 years ago, there was an African-American man who came to me and he said, I'm having a problem with my nature. Your nature, okay. And he kept saying that my nature, I have a problem with my nature. I did not know in Black culture it has to do with sexuality, and basically he was having sexual dysfunction. Not even on my radar at the time. And I just kept saying, what kind of nature? And he would go into different subjects, and finally, just tell me more. Just tell me some more, how it's happening, when it happened. And it took me a while. And it changed me. I said, wow, people have, if I don't get the word used, I should shut up and get more from the person. So that's the best I can say. When people, I might not even know someone feels stigmatized. I just need to know, I could sense a discomfort and just go with what my gut's feeling. Like, you seem uncomfortable. Is it something I've said, or are we not getting to the point? Am I missing it? So it has a lot to do with me just trying to read other things. Because I'm shocked at how much I don't know about different cultures. I'm just, African American is a big part of our society, and Latino, I guess, and white are the three big ones in our, but there's so many other cultures we've learned over the last 50 years I have, with really specific things that I don't know. So.
And I just will add, I think, this notion of cultural humility it becomes quite critical, because even within different ethnic groups, there's a tremendous diaspora that is quite heterogeneous. Again, speaking as a South Asian, my family immigrated from Gujarat, which is obviously a different section of India than where Ashwini's family immigrated from, and so there are also some very unique differences potentially in the ways in perhaps we, just stemming just initially just from diet, but potentially other areas as well, as we think about how we approach or view or how we are taught to view the world. But Dr. Nadkarni, any other your thoughts on how you have thought about stigma in as a South Asian, but also working with other patients?
Yeah, I think one point I want to highlight is this concept of self-stigma too. I had a chance to speak in a forum where we discussed our South Asian identities and what brought us to becoming psychiatrists. And I want to point out, that as a South Asian physician who's a psychiatrist, I think that I've seen some self-stigma in myself along the way, and what it meant to me to become a psychiatrist as opposed to necessarily pursuing a specialty in medicine, which maybe most South Asians are likely to pursue. And also recognizing how, even within ourselves, when you become a psychiatrist, you often are told, well, this is a specialty that doesn't make money for the hospital. And I think that that's actually something that reinforces some of that self-stigma related to treatment. I think that I have worked very hard over the last 10 years to recognize when I'm self-stigmatizing and try to overcome that and come to care with an absolute confidence and belief and faith in what I'm offering to patients, that it really can help them and does work. So you cannot have any kind of self-stigma. Well, I think it's impossible to remove all self-stigma, but you have to have some awareness of where it is there. The second piece of this is, I will say, I do reflex back to brain medicine. I do, and I try very hard to explain to patients, what is the underlying pathophysiology of psychiatric disorders, and point to, the fact that 200 years ago, Freud was out there treating Parkinson's and MS with psychotherapy, and modern medicine has moved us so much further along. But I think that last piece is going back to what Dr. Levy said, which is, offering our patients choices, really listening, being curious, being open and honest, but offering them choice and recognizing that, a patient doesn't need exact treatment from me alone to be well. My job is to simply offer them choice, to try to break it.
Can I just say I love the word curious, that we're often interrogating or we're filling in the boxes on our epic form that you have to finish but we lose our curiosity. And if we just stay curious, just about anyone can do a good interview with somebody.
Yeah, that's a great point. It's a really nice way of putting it.
I think we have, Dr. Simon has arrived, and so I'm going to transition since he's here. And again, to our audience, we had just a little technical, but we want to keep this dialogue going. And as Dr. Simon, I'm going to add spotlight here. Okay. And okay. So it's my honor to introduce Dr. Kevin Simon. He is the inaugural Chief Behavioral Health Officer for the City of Boston. Dr. Simon serves as attending psychiatrist at Boston Children's Hospital, instructor in psychiatry at Harvard Medical School, and Commonwealth Fund Fellow in Health Policy at Harvard University. He clinically practices as child, adolescent, and adult psychiatrist and addiction medicine specialist, caring for the youth, young adults, and families through the Adolescent Substance Use and Addiction Program at Boston Children's Hospital. And he has received federal funding for his work focused on the intersections of mental health, substance use, and justice involvement. But really, the pride of the city of Boston is really that he is our first Chief Behavioral Health Officer, which is a newly created role just this past year. And Dr. Simon, truly honored to have you here. And I will turn the podium over to you.
Yeah, no. One, thank you for inviting me, and apologies for significant delay here. Being in a public sector role, seemingly there are always things going on. Hello, Dr. Levy, as I see you, and I don't want to mispronounce your name, Ashwini. How would I pronounce your last name?
No problem, Dr. Nadkarni.
Oh, Nadkarni.
Nice to meet you.
So given the time, I guess I just kind of want to highlight a couple of things with regards to mental health from a city level or public health level. So obviously, I suspect we've talked about the challenges that we've seen over the last couple of years. Something that I've come to even more strongly realize in the couple of months that I've been in this position, listening to different pockets of communities within the greater Boston area, is while we have significant advancements, particularly for those of us who are in the Boston area in terms of our medical mecca, as some would say, there are really strong and large amounts of personnel and people who don't get access to places like Children's that I work at, or MGH and others. And this idea of workforce shortage and long wait lines or long wait lists certainly is true. We do have to figure out kind of unique ways to reach people. And so, one of the things that we'll be doing is it can be best termed as like a mental health tour, in the sense of actually, bringing persons almost like here we are, right, in the virtual world, into the community, that's in East Boston, that's in Brighton, that's in Mattapan, because time and time again, when I'm listening to constituents, the first thing that they'll say is that they don't see people like me, and it's very hard to get access. And certainly the educational timeline to create, clinical social workers, psychologists, physicians is rather long, but the needs are acute and now. I think that's the most striking thing that I've recognized in the first couple of months. The other is, when we think about mental health, obviously there are multiple social determinants of health that impact that, right? So economics, education, neighborhood. And you start to really recognize that the social political climate that we're in is also particularly negatively impacting individuals' sense of self. So while I'm speaking rather negatively, there is hope, because I think, forums like this and having experts like this around and available indicates that the needs that people have, like they're not, particularly within the mental health space, are not drastic, right? They're just saying, I don't have someone to talk to. I don't have someone who can listen to me. And I think the reason I like to do what I do is I'd like to listen, and it happens to be the one aspect of healthcare that we can't do fast, right? You can do a lot of things fast. I could type fast. I can have my smart phrases, but to actually give people time and listen, I just cannot do that fast. And I think that's what we're coming up against in our healthcare system, is super efficiency up against people that have really significant concerns and want that patience for Dr. Levy, myself, or others to just be present. So those are just a few thoughts that I have with regards to public health and the mental health space.
So I think that was beautiful. Thank you again. I'm going to bring everyone back here into this panel for just some final thoughts before we, sort of transition to our next book. Because I think one of the most important pieces here that you said was this conflict of time and resource, and how much, at some point you have to give a certain amount of time to patients to deliver effective care. And so I guess maybe I'll ask each of you sort of in maybe some just concluding, thoughts. What is the one way that you see that we are able to address that conflict, especially from a community-based perspective, and as a cross-cultural perspective, this challenge of having enough time versus having enough resources, and what is one solution or one idea or innovation that you think putting forward? So, Dr. Simon, I'll let you be the last speaker since you have some time to think about it. But I'll start with Don first, just to, if you can give a your thought in a minute or so.
I think we have to change the culture of medicine. It's I had the same issue with when I was a primary care doc. We lost money for the hospital. We lost money for the hospital until somebody put together that actually every primary care doctor brought in 100 grand by the local referrals, and that was the hospital that people chose, and they went to your brain surgeon and your heart surgeon. So suddenly we had status, primary care docs. Somehow it has to become in our culture, the work we do, the time work, should be compensated, respected, and seen as central to most people's healing. So, there's this thing, you're supposed to practice at the top of your license, meaning don't do anything except let someone else write the note, let someone else bring you in the room, let someone else schedule you, and just do your one thing and then get out of the operating room or the consulting room. I think that's got to go. We're all healers and we need time. And that's probably the most important thing I can say. And we need to fight within our own medical societies and hospitals.
Thank you. All right. Ashwini, any thoughts?
So if I were going to integrate one concept from what I talked about, it would be incorporating that collectivist approach into care, right? Like really working together as teams. I have had setups in our department, in our clinic, where I actually evaluated the patient with a colleague who was a social worker, and we worked with that patient together. We heard everything that they said together. And then afterward, we could split up tasks, or we could also play to our strengths. I suppose that is that concept of top licensure, Dr. Levy. But it felt like we were each giving as much time as we had to that patient, but we also had each other. I think that's such a key point, because that conflict between need and time, it injures us, right? That's the moral injury. That is the difficulty we all face as treaters and clinicians. And we need each other. We have to be working in teams. We have to be talking about that. I think, another point Dr. Levy made that is so powerful, right, is political advocacy. There's no question about that. We have to be changing things at the organizational and at the national level with these issues and advocating for change. Absolutely. But if we have each other and we're together on the front lines, then maybe we can be more powerful making those changes.
And Kevin, as a public health officer and physician, your thoughts?
Yeah, no, so one, I wholly agree with the last comment about kind of like sharing an evaluation. I know certainly in our pediatric inpatient unit, that's actually how we would do our intake. It's social worker, nurse, child psychiatrist, psychologist, all together in the room with the patient. Yet in the outpatient world, that's a little bit more difficult, or at least we create it to be difficult given the way that things are certainly structured. In terms of advocacy, definitely need to do that. In terms of recognizing that we're not actually competing against each other. So when Dr. Levy mentioned the comment about time, I recall there was an article, and it seemed to be that, there was one primary care provider acknowledging differences in pay. And it's like, oh, you shouldn't actually be mad at your other physician colleague. What we need to be doing is advocating, against a system that is set up in such a way that I'm going to look to my physician colleague rather than to look at, wait a minute, why is the system treating him or her differently? In terms of what could happen today, I will give kudos to the VA here. I don't see many academic clinics where psychiatrists will be running a group, because group payment seemingly is not as high as individual. But in terms of actually being able to spread and scale services kind of widely, group therapy is something that again, in terms of what could happen today, is something that I certainly know as a trainee, being a participant within group therapy, group training, seemed to be pretty powerful. And when we're talking about, certain communities and cultures having fear about engaging in this process of sitting down and talking with someone that perhaps does not look like them, because it's going to be very difficult to get a one-to-one racial concordance across, entire city, let alone a state. There's a good chance you're likely to feel less discomforted if you see other people in this process together, even if the central person that's leading the group looks differently, right? Because you see others that reflect your community, reflect your culture. So that's something that I think we can certainly do, and we will be trying to do as a public health commission.
Well, on that note, I just want to thank this esteemed panel for taking just really some important reflections and really setting up the stage for what really is. We have tremendous work ahead of us, but I think with this type of sort of collective wisdom, I think a lot can happen and a lot can be done. So with that, thank you to all three of you for being here with us. We will now take a brief 13-minute break, and we will start at 10:20 or 20 minutes after the hour on our next panel, which is exciting, really bringing in our faith community. And so what can our faith communities teach us about as we think about the lived experience of depression? So please join us. You're going to exit out of this room and then re-enter the next room in just a few minutes. So thank you, everyone, and look forward to seeing you at the next session.
Thank you.